So let's move on to the next talk. Can I request Dr. Debu Chakraborty to have his talk on? It's my privilege to introduce him, Dr. Debdulal Chakraborty, who is a senior consultant at Disha Eye Hospital, Kolkata. He has done his fellowship from the prestigious Shankanetralaya, Chennai, and training in ROP from Orbis. He has been an international observer at Bascom Palmer Eye Institute, Miami, and he has been a reviewer of different medical journals, and he is PI to multiple trials. So over to you, Dr. Dev.
So thank you for the kind and warm introduction, and thank the organizers for this opportunity. So I'll be speaking on new paradigms of DME management, transforming clinical practice. So this is something Dr. Devendra has already so nicely set up, and we are in an epidemic of diabetes, and unfortunately, like he mentioned, it needs repetition that most of these patients are in the working age group. So there's going to be a huge jump of these patients from 537 million in 2021 to 783 million in 2045. So that's a huge jump. And the other problem is it's going to have a huge economic impact. And at this point in time, we have around 75 million Indians affected by diabetes, and it is expected to increase to 124 million by 2045. So that's a huge burden that we are looking at. And of these, 27% of these diabetics have some form of DR, 25% would be NPDR. You will have a DME in 5% and PDR in 1.5% of these situations. So like gentleman just pointed out, you have this thought of multiple injections being necessary for treatment of DME by with ranibizumab or maybe aflibercept. So this is a bone of contention at times. And in India, what the scenario is that you hardly get to give 2 injections or 3 injections over a year in most of these patients. Patients don't agree to many injections. The other problem is they drop out. 66% of DME patients drop out within the first year of treatment. So if you look at the real problems based on a survey conducted and presented at APVRS, so fluid is a problem that is recognized by all of us, and high treatment burden, high cost of treatment, and also high injection frequency is something that all of us retina people and comprehensive ophthalmologists would agree on. So unresolved retinal fluid, it in turn leads to increased injection frequency, resulting higher rates of non-compliance in DME. Now, if you look at various publications, the treatment failure rates can be between 25 and 40% across all agents used. And the Indian DME patient is special in the sense that non-affordability comes as a big problem for us, and most of us have to treat PRN. And there's a low number of injections giving rise to non-improvement of vision, and this is a kind of a vicious cycle that goes on and on. So the need of the hour is increased efficacy, increased durability, and both at a reasonable cost. So brolucizumab may be able to dry the retina better and be more effective in DME, and because of its durability, reduce the injection burden also. So we all know about brolucizumab, and the special thing about brolucizumab is the small molecular size, which can allow pumping in of more molar dose of the drug. So Dr. Devendra has already spoken about kite and kestrel studies, and just to kind of re-emphasize that 70% of brolucizumab patients could be actually successfully managed on Q12 weekly interval in the kestrel and 16 week up to 16 week in the kite studies. And half of these patients actually could have more than these long intervals of treatment. Now, of course, he also mentioned that you need fewer injections with brolucizumab compared to aflibercept. Of course, there was no significant, adverse events in these couple of studies. And if you look at the meta-analysis of publications on brolucizumab, so it is thought of as a drug that has the potential advantage in efficacy and durability over other anti-VEGFs, as we have just noted in the discussion, in treatment of DME and also in diabetic retinopathy as a whole. So we'll just briefly touch about our experience. So this is the first patient actually I treated with brolucizumab. So after having many injections and raised IOP following IVTA, and we offered brolucizumab. And as you can see, after the first injection, there was reduction in in the edema. And you can see some intraretinal fluid, some hyperreflective foci here, which is kind of going down after in 2 months' time. This is just one injection, please note. This is after 3 months. So we actually observe these patients every month. And, at 4th month, the fluid was coming back. Sir mentioned that, we shouldn't wait for the fluid to come back. That's a very important point. So you have to find your own sweet spot, so to say, to actually treat these patients and don't repeat, the fluid from coming back. This is another patient, 11 injections of ranibizumab and a very strong family history of glaucoma and fairly controlled diabetes, I would say. We offered aflibercept, but the patient refused because of cost issues. We offered brolucizumab, and this is what happened. So after a month, there was this, area of intraretinal fluid. We just held back, going by our experience. As you can see, at 3 months, actually, it has come down from the 1 month, IRF. And this is actually interesting. This is what happened at the 4th month. There was no increase in fluid. And this is, of course, the octa showing, the distorted macula. So you can really have good results in these patients. So this was basically the impetus for a very small publication that we had. Long story short, the key finding was brolucizumab exhibited good visual acuity outcomes lasting up to 16 weeks for treatment of recalcitrant DME. So, what is the story beyond the publication? So, story since then for the first patient is that we've injected 10 injections from 2020 on a PRN basis, and vision is 612. This is just last month. So we also had a similar publication with recalcitrant cases with my friend Ashish, and we actually saw the same story. So initially you have this improvement up to 12 weeks, and then it wanes off. So both with vision and CST, and so like I mentioned, the sweet spot could be around 12 weeks, 13 weeks for many of these patients. So the key points from this study was 2.2 injections roughly over a 6-month period. And most of these patients could achieve 16 weeks treatment-free intervals, and none of these patients reported any ocular adverse events. Now, recently we've published this BRADY study, which is brolucizumab versus aflibercept for recalcitrant diabetic macular edema. And we had 30 patients on the brolucizumab side and 28 in the aflibercept group. So if you look at the visual acuity changes, this is something that we had to fight with our ethics committee because there was a significant difference in the visual acuity to start with. The brolucizumab group had worse visual acuity, and this was not actually similar with the aflibercept group. But as you can see, some improvement in these really bad cases following brolucizumab. And of course, one has to remember this is again PR, and so there's some shooting up here. And the CMT changes, as you can see, you have a reduction in both the groups with aflibercept showing a spike here at around 40 weeks. Now, subretinal fluid and intraretinal fluid, similar story. You have significant reduction in both the groups, and brolucizumab group did better compared to aflibercept. And we'll skip this. And the potential, for brolucizumab is there for sustained visual acuity benefits. You have actually 76% patients of DME which were dry following brolucizumab injection in this study, and 50% with the aflibercept. So there was a significant difference of the drying effect with brolucizumab. And of course, we didn't have any IUI. We actually have not had any IUI with brolucizumab in DME. So we've used a fair number of brolucizumab injections. Actually, at Disha, we've used more than 8,500 vials of brolucizumab across indications. And, like has been mentioned in the other studies, we had 3.93 injections over a year with brolucizumab compared to 4.75 over 52 weeks with aflibercept. So this is something that works in favor of brolucizumab. So to summarize, with brolucizumab, better anatomical results are possible, better durability is possible. We found it to be safe in Indian eyes, and VRSI has come up with a recent publication of which we are also a part of, which shows a significantly lesser number of IUI in Indian patients. And the findings support brolucizumab as a promising treatment for DME with potential to reduce treatment burden. I'd like to thank you all for your kind attention.
Thank you, Dr. Debdu. Just for the sake, for the information of all the audience here, Dr. Debdu is one of the highest users of brolucizumab across the indications in our country. probably his numbers are much more than the kite and kestrel studies individually per indication, I believe. So how much is the experience with you for diabetic macular edema? How many injections?
Sir, thank you for those comments. But actually, at Disha, we see 15 lakh patients in a year, and we have 27 odd retina guys. So it's a combined effort, not my effort only.
I'm not trying to compliment. I'm just coming to it that we
Sir.
have an experience bigger than what the kite and kestrel we quote whenever we talk about IOA and the fear of using this molecule. That's why I'm trying to tell
Sir,
the
we've-
magnitude of the in
Absolutely,
this
sir.
indication. Yeah,
Sir, we've at this point in time, the patients out of these 8,500 vials, we've had around 55 to 60 cases of IOI. None of them had needed vitrectomy. One patient actually, in the very initial phases, there was a patient who actually was injected dexamethasone. But subsequently, we've been using only topical steroids. Some of these patients who are non-diabetics, we've obviously, because these are NAMD cases, all of these are NAMD cases, we've used oral steroids if we thought, but now it's mostly topical steroids. And for the last 6-7 months, I don't know why, and this has been something that I have come to know from some other friends also, we've had no IOI, touch wood. We've had no IOI for last 6-7 months. So I think something good is in the offing.
number of injections out of the number of for diabetic macular edema you have treated approximately.
Sir, it will be more than 2,000 vials.
2000.
Sir.
So, for the sake of viewers here, just observe all the audience, the overall cohort, the study group of kite and kestrel might be 300 plus cases in kite and how much?
Absolutely, sir. More than that, much more than that.
And that was initial 2 years. With this such a volume, I think the fears which were expressed needs to be negated, and this molecule which can definitely help our country, where as the respectable sir from the audience pointed out that the number of injections which we need is going to be a burden and most of our patients can't afford it. We have a solution to it. Sir, Dogra sir, your comments.
I absolutely agree. I think we can have a little more discussion maybe after the last talk, because we're going to have a other experience also, and that will be the right way to go. Perhaps that's what we